Welcome to the Multiple Sclerosis Virtual Grand Rounds Educational Series. I'm Alex Rae-Grant, Staff Neurologist at the Mellen Center for Multiple Sclerosis at the Cleveland Clinic. I'm the moderator for this series. It gives me great pleasure to introduce our speaker for today, Dr. Richard Rudick. Dr. Rudick is the Director of the Mellen Center for Multiple Sclerosis Treatment and Research. He is a Hazel Pryor Hostetler Professor of Neurology at the Cleveland Clinic and also serves as Vice Chair, Research and Development for the Neurological Institute at the Cleveland Clinic. He has been a force in developing our modern understanding of MS as a disease, as well as a force in developing new disease-modifying agents for this previously untreatable disease. He's been at the forefront of most new directions for understanding and treating multiple sclerosis. In this talk, he will introduce us to a very new idea in MS treatment, that of trying to achieve no evident disease activity, or NEDA status, for as many patients as possible. This is really a novel idea in the MS world, and to date, we haven't as a field focused much attention in this direction. It is moreover a concept that could take us to the next level in controlling this difficult and disabling condition. He will walk us through the definition of NEDA, the literature on NEDA coming out of recent clinical trials, and evolve the concept of how we will use this concept to enrich our treatments of patients with MS. Rather than just putting people on medicine, following them no matter what happens, Dr. Rudick is telling us to try to achieve NEDA in a population. This will push us to monitor, treat, and follow patients more carefully, and will make us have a greater willingness to be flexible in terms of disease-modifying agents and how we use them.
Hello, I'm Richard Rudick. I'm the Director of the Mellen Center for Multiple Sclerosis Treatment and Research at the Cleveland Clinic in Cleveland, Ohio. I'm going to speak with you today about treating to target in multiple sclerosis and introduce the concept of disease-free status. These are my learning objectives. I'd like to define the concept of no evident disease activity, identify data on NEDA from clinical trials, comment on how rheumatologists have defined treatment target in rheumatoid arthritis, apply the treat-to-target concept to the office setting, and highlight some important unresolved issues. Before I start, I would like to give a couple of polling questions. The first question is, I have heard or read about disease-free status or no evident disease activity results from MS clinical trials. Yes, no, or not sure. The second polling question is, I routinely discuss the treatment target with MS patients when starting or changing disease-modifying drugs. Yes, no, or not sure. And lastly, I believe it is important to establish a treatment target for each MS patient on disease-modifying drugs. Yes, no, or not sure. First, some nomenclature. Disease-free status is commonly used in the MS literature, but it's discouraged because we really lack a methodology to fully evaluate ongoing MS pathology. Disease activity-free status is better, but we also lack standard methodology to assert that we have eliminated all disease activity. For example, we may observe 2 gadolinium-enhancing lesions with standard gadolinium, but we may observe 10 if we use triple-dose gadolinium, or 15 if we use triple-dose with a delay in the scan time. No evident disease activity is probably the best term for this concept, although please note that it does imply the neurologist has monitored the patient for disease activity. Again, to my outline. Currently, we have 10 MS disease-modifying drugs. These approved drugs reduce brain lesions and relapses, and they afford secondary neuroprotection, meaning they protect the brain from the neurodegeneration caused by brain inflammation. Individual patient response to these 10 disease-modifying drugs varies. And we have no standard approach currently to define the treatment target, to monitor patients in practice, to sequence therapy, or to make decisions about changing therapy. Disease-free status, or no evident disease activity, is a concept developed from clinical trials. This is a quote from the Avradova paper in Lancet Neurology in 2009. This was the first report of the disease-free status concept. This was a report from a secondary analysis of the AFFIRM trial, which was a placebo-controlled trial of natalizumab or Tysabri in relapsing MS. Our aim was to develop composite measures that can be applied in clinical practice and used as a measure of disease remission in clinical studies. Therefore, relapses, progression of disability sustained for 12 weeks, GAD-positive lesions, and new or enlarging T2 hyperintense lesions were taken into account. This definition has taken hold, and there's now an emerging literature on disease activity-free status from clinical trials. The common definition is no new or enlarging T2 lesions, no new GAD-positive lesions, no relapses, and no confirmed EDSS worsening. Please note that atrophy or T1 black holes are not included in the definition. This is data that was in the Havradova paper in Lancet Neurology. Again, this was the first report of the no evident disease activity status in any clinical trial. On the left, you can see the proportion of patients with no clinical activity during the 2-year trial, 39% in placebo patients and 64% in natalizumab patients. In the middle, you can see the proportion of patients with no MRI activity while on the trial. And on the right is a combined composite of no clinical or imaging activity. That's termed disease activity-free status in this paper. I'm calling it NEDA. So NEDA at 2 years was present in 7% of placebo patients and 37% of natalizumab patients for a 5.3-fold increase in this study. This is similar data from the study of cladribine published in Lancet Neurology in 2011. Cladribine is no longer being developed for MS because of the toxicity or tolerability profile. However, Giovannoni reported this data in 2011, so I've included it. Cladribine was tested at 2 different doses, shown in salmon color and green, and the placebo is shown in blue. Focus your attention just on the right-hand panel. That shows that in placebo, 16% of patients had no relapse, EDSS progression, or new MRI lesions, while for cladribine, it was approximately 44% for a 2.8-fold increase in NEDA in the treated group. This is NEDA status from the FREEDOM study, FREEDOMS 1, which is oral fingolimod. The overall disease-free patients are shown on the left-hand side, and this particular report, given by Kapos at the American Academy of Neurology, breaks the data down into patients who were treatment naive and patients who were previously treated in the middle and right-hand panel. The overall disease-free proportion for placebo patients was 13%, and for fingolimod 0.5 milligram, the currently approved dose, 33% for a 2.5-fold increase. This is NEDA status in the recently reported DEFINE study. This is BG12 or Tecfidera. Patients in the placebo arm were 15% NEDA status patients, and patients on the BID of BG12, 28%, for a 1.9-fold increase. This is a table that combines all four studies. These are placebo-controlled 2-year clinical trials showing the proportion of NEDA in the placebo arm ranging from 17 to 16% depending on the study, and the active arm ranging from 28 to 44% depending on the study. The fold decrease or the fold increase in NEDA status is shown on the right. Now I would like to show you some emerging results from active arm comparison studies that report NEDA status. The first is the NEDA status in the TRANSFORM study, which is a trial comparing fingolimod with interferon beta-1a Avonex. In this slide, you can see that 34% of the Avonex patients were disease activity-free, compared with 46% of the fingolimod 0.5 milligram patients. Fingolimod increased the NEDA status by 1.4-fold. This slide shows the NEDA status in CARE-MS1, which was a trial of alemtuzumab versus interferon beta-1a sub-Q, or Rebif, in treatment-naive patients. 27% of the Rebif patients were disease activity-free, compared with 39% of the alemtuzumab patients. Alemtuzumab increased disease activity-free status by 1.4-fold over the active comparator Rebif. In this slide, NEDA status was reported in the CARE-MS2 study, which was alemtuzumab versus interferon beta-1a sub-Q Rebif. But in this study, the patients were required to break through platform or existing disease-modifying drugs before entering the CARE-MS2 study. So these patients were more active, and not surprisingly, the NEDA status was lower in the CARE-MS2 study than the CARE-MS1 study. In this study, 14% of patients on Rebif were disease activity-free, compared with 32% on alemtuzumab, a 2.3-fold increase with alemtuzumab versus the active comparator Rebif. This table then summarizes the proportion of no disease activity in the active arm trials that I just reviewed: TRANSFORMS, CARE-MS1, and CARE-MS2. In each case, the active arm being tested compared with interferon therapy and increased the likelihood of being disease activity-free between 1.4 and 2.3. Now I'd like to move to lessons that we may learn from the rheumatoid arthritis field. This is an update from the 2008 American College of Rheumatology recommendations for the use of disease-modifying anti-rheumatic drugs and biologic agents in the treatment of rheumatoid arthritis. This is a quote from the publication. The treatment goal for each RA patient should be low disease activity or remission. In ideal circumstances, rheumatoid arthritis remission should be the target of therapy, but in others, low disease activity may be an acceptable target. This gets across the concept that no disease activity may not be an appropriate treatment goal for all cases. These studies point out the fact that with disease activity remission, there may not be complete disease remission in rheumatoid arthritis, and this may be very similar to the circumstance in multiple sclerosis. Brown, in Arthritis and Rheumatism, found that in patients with confirmed activity remission, 52% still demonstrated bone marrow edema by MRI, and 96% still demonstrated synovitis by MRI. Doan and colleagues in Annals of Rheumatic Disease showed that in complete remission, 63% of patients still demonstrated bone marrow edema by MRI. This may be a similar circumstance in multiple sclerosis, so I prefer not to equate no evidence of disease activity with disease remission. According to the American College of Rheumatology, these are the steps in defining progress toward achieving rheumatoid arthritis remission. This is instructive for multiple sclerosis because we need to move through these steps as a field in order to develop standard practice for identifying treatment targets in clinical practice. Step 1 is to select the objective core clinical and lab measures. Step 2 is to determine the thresholds to define remission using those methods. Step 3 is to determine the added value of subjective physician or patient-reported outcomes. Step 4 is to construct candidate lists of remission definitions. Step 5 to test their predictive validity. 6 is to test their face validity. 7 is to recommend definitions for use in research trials. And 8 is to validate these definitions in observational data sets so that progress can be made in research and clinical practice. We need to follow a sequence along these lines in the multiple sclerosis field. At present, we're at the very top. So let's move to identifying treat to target as a goal in MS practice. I'll start with a case report. This is a 33-year-old woman with optic neuritis. Her MRI shows 5 periventricular lesions, 2 of which enhance with gadolinium, 3 of which do not enhance. So this is my question for you. Which of the following is the patient's diagnosis? 1, clinically isolated syndrome. 2, possible multiple sclerosis. 3, probable multiple sclerosis. Or 4, multiple sclerosis. The answer to this question is 4, multiple sclerosis. According to the most recent criteria for MS diagnosis published by Pullman and colleagues in the Annals of Neurology, this person has definite MS based on a characteristic clinically isolated syndrome, optic neuritis, together with both gadolinium-enhancing and non-enhancing brain lesions. The patient was started on interferon beta-1a, Avonex, with a follow-up plan being visits every 6 months and MRI scans each year. Which of the following is the treatment decision, relates to the treatment decision in this case? The treatment will, 1, improve the recovery from optic neuritis. 2, is based on Class 1 evidence from randomized placebo-controlled clinical trials. 3, is the best choice of disease-modifying drugs based on comparison studies. And 4, will not change the long-term disability due to MS. The answer to this question is 2. The treatment here is based on Class 1 evidence from randomized controlled clinical trials. A randomized double-blind placebo-controlled trial demonstrated reduction in subsequent relapse in patients with clinically isolated syndrome at risk of developing MS. That was published by Jacobs and colleagues in the New England Journal of Medicine in the year 2000. There is no evidence that treatment with interferon will change the extent of recovery from optic neuritis. No direct comparison studies have been done to determine which treatment is best for patients with optic neuritis at high risk of relapsing remitting MS. And lastly, most experts believe that early and effective MS treatment improves the long-term prognosis. At month 6, the patient was still having mild flu-like symptoms consisting of headache and muscle aches, but no new MS symptoms. The plan was to continue interferon beta 1A Avonex. At month 12, the patient was no longer having flu-like symptoms, had no new MS symptoms, but the brain MRI showed 2 gadolinium-enhancing lesions. Which of the following would be the best decision at this point? 1, interferon beta neutralizing antibody testing. 2, continue Avonex. 3, discontinue treatment. Or 4, switch to fingolimod or natalizumab. The answer is 4, change therapy. Neutralizing antibody testing would be rational because the presence of interferon beta neutralizing antibodies might explain active disease. However, neutralizing antibody testing would not change the need to change therapy, so it's unnecessary. Patients with MRI activity while on interferon beta have a poor prognosis, so continuing Avonex is not appropriate. Discontinuing treatment entirely is illogical. If treatment was indicated in the first place to reduce disease activity, it's still indicated. Lastly, advancing treatment to a more effective therapy is appropriate. In particular, the use of fingolimod in this situation is supported by a randomized active arm controlled study published by Cohen in the New England Journal of Medicine in 2010. The patient understands her options and agreed with the plan to switch therapy. After discussion, the patient elected to use fingolimod. The patient tolerated fingolimod well with no reported side effects. Monitoring for toxicity was negative. After 1 year, no new MS symptoms and no new MRI lesions were observed. The plan was to continue fingolimod and monitor. Identifying treat to target as a goal in MS practice appears to be important. However, discussing treatment target is new in the MS field, and some neurologists don't discuss treatment targets explicitly with their patients. This is a poll that was done by Dr. Gavin Giovanoni, who's in the United Kingdom and has a patient blog. He asked his patients, has your neurologist discussed the concept of being disease activity free with you? 14% said yes, and 86% said no. This indicates that at the time of the poll, very few neurologists were discussing being disease activity free with their patients when starting disease-modifying therapy. Monitoring MS patients on disease-modifying therapy. I recommend discussing treatment goals with the patient, taking into consideration various important factors. It's important to set a visit frequency schedule and a monitoring plan with a focus on compliance, side effects, and toxicity. Monitoring for relapse and for new lesions on follow-up MRI scans. I also recommend a patient global assessment of how well they're doing on the drug and satisfaction with the current disease-modifying drug. These are important unresolved issues. Is no evident disease activity an important therapeutic goal? I'll discuss that and then highlight some other important unresolved issues. It seems as if no evident disease activity would be a clinically meaningful and important outcome. This is supported by many studies in worse outcome in patients who develop new MRI lesions while being treated with interferon beta. This is a study to illustrate the kind of data that is in the literature. This was published by Prosperini and colleagues in the European Journal of Neurology in 2009. 394 relapsing remitting MS patients started on interferon beta 1b and were followed for nearly 5 years on treatment. The response variable was the number of new T2 lesions after 1 year on therapy. And the outcome variable was the proportion of patients who worsened on the disability status scale. Overall, 30% of the patients worsened after 4.8 years in this observational study. The bottom line on the study was that new T2 lesions at 1 year predicted disability worsening over the entire 5 years, and this is the key data point from the study. This slide shows the proportion of patients who had disability progression during the 5-year study according to the number of new T2 lesions they had at 1 year. On the left, the bar shows that very few patients with no new T2 lesions at 1 year developed disability, while as we move to the right, increasing numbers of new T2 lesions at 1 year predicted an increasing proportion of patients with disability progression by 5 years. On the far right, you can see that over 80% of patients with 3 or more new T2 lesions 1 year after starting interferon beta had disability progression by 5 years. This is the second study I'd like to highlight. This was published by Mellen and colleagues in the Annals of Neurology in 2013. This was a 15-year follow-up study of patients who completed 2 years in the pivotal trial of Avonex, intramuscular interferon beta-1a for relapsing-remitting MS. The patients were all evaluated to determine their disability status at this 15-year follow-up time point. The data shows the patients broken into quartiles according to their EDSS score at the 15-year follow-up visit. Quartile 1 had a median EDSS at follow-up of 1.5, which is very low, while quartile 4, meaning the worst quartile, had a median EDSS of 8.0, meaning that the vast majority of patients in this group were either deceased or in nursing homes or assisted living. The question in this study was what factors during the original clinical trial predicted this very bad outcome. And the data is summarized on this table. These were the predictors of this long-term, very bad outcome in MS patients treated with interferon beta 15 years earlier. The activity during the 2-year trial, measured by the MRI scan, were the best predictors of this poor outcome. The odds ratios, which are shown on the right, indicate the odds of being in this worst quartile at 15-year follow-up. If a patient had 2 or more gadolinium lesions during the 2-year clinical trial while on interferon, the odds ratio of severe disability was nearly 9. And you can see the other predictors and the odds ratios below. This indicates that disease activity while on interferon carries a very poor prognosis and therefore supports the use of relapse and MRI lesion monitoring while on disease-modifying therapy. So this is a list of important issues as I see them in moving the no evident disease activity concept from clinical trials into practice. A core set of measures needs to be developed and standardized in order to define and monitor for NEDA. For example, relapses, MRI lesions, and disability progression would be good candidates. A reliable method is needed to quantify new MRI lesions in clinical practice because visual inspection is somewhat imprecise. A visit frequency needs to be determined, probably every 6 to 12 months, but this needs to be individualized depending on the drug and the patient's circumstance. The patient's role in deciding the treatment target needs to be determined. I recommend discussing the target for treatment with each individual patient because patients individual perceptions about disease severity and threat from MS and risk tolerance differ. The other question is whether we can achieve NEDA in our MS patients and whether the benefits of achieving this with more potent but somewhat more toxic drugs justify the risks. In terms of the patient and family roles, I believe both the patient and the family can and should be effective partners in deciding on the target for MS treatment in practice. So in summary, we have 10 disease-modifying drugs, but none are completely effective in all MS patients. No evident disease activity is a new concept that comes from the clinical trial literature, but is being applied for the first time in MS practice, similar to the way treat to target has been applied in the past in the rheumatology field. Up to 40% of patients in placebo-controlled trials of monotherapy have achieved the NEDA status during a 2-year clinical trial. Rheumatology has taught us the pathway to develop treatment targets in the practice setting. And treating to target in the office requires individualized planning with each patient. Unresolved issues include the methodology, determining how to measure the impact of NEDA, and deciding on the role of the patient versus the physician in setting the treatment target. Thank you very much for your attention.
Thanks, Dr. Rudick, for your thoughtful and worthwhile comments. I can't express enough how much it helps to have your ideas about NEDA to work from both in a research and in a clinical sense. It is clearly important for us to target more complete control of disease parameters in our population, particularly since we now have a variety of agents with different mechanisms of activity, measures of efficacy, and toxicity profiles. We should be better able to match patients with effective therapies for their particular situation rather than using a one-size-fits-all process. We also need to be more assiduous in controlling disease so that we can help our population, as much as possible, achieve the best outcomes we can give them. We need a definition such as NEDA to help us measure and monitor how we're doing to achieve these outcomes. No longer can we follow a patient on an agent having new lesions on MRI or new relapses and just assume that this is okay. You've helped us set our sights higher in the care of our population.